Hello, everyone. Good morning. So today we are having Ms. Merzia Maskati with us, and she is a founder of Speech Dysphagia Language Clinic, which is a private clinic in Mumbai that offers speech dysphagia, language, and occupational therapy services. She also serves as a consulting speech therapist at Breach Candy Hospital Trust, and she specializes in autism spectrum disorders, social communication disorders, augmentative and alternative communication systems, and fussy picky eaters. She has trained and certified several clinical fellows. We are very happy to have you here with us, ma'am. Urusha, you can
Thank
take
you
over.
for having me. Yeah.
Yes.
Yes, thank you so much, ma'am. So I'll just brief everyone about why are we doing this and what exactly are we doing. Today, we all know that October has been the AAC Awareness Month. So on the last day of October, and throughout the month, we have attended so many amazing webinars, some of which were given by ma'am herself. So on the last day of the AAC Awareness Month, we have decided to compile everything that we've learned in terms of case studies and answer a few questions that, in terms of the clinical applications of AAC. So that the next time you have cases in any of these domains, you'll not be lost on where exactly and how exactly to go about. So Roshali will read out the cases and what questions will ma'am be answering us.
Right. Thank you, Urvisha. So we'll be discussing about four case studies. The first case will be a 3-year-old child with global developmental delay, a known case of cerebral palsy. His receptive and expressive language age is less than 1 year, and child is completely non-verbal, and few meaningless vocalizations are present inconsistently. He does not point to or does not intend to ask for any needs. Second case study is a 5-year-old male with a multiple handicap where child can use few jargon words to convey his basic needs like mama, papa. He says boo for water and mum for food or biscuit. He points and cries out for the desired things. The third case study will be a 10-year-old child. She is a female having autism spectrum disorder. Her cognitive age is around 4 years and receptive language age about 3 years, and does not have any communication intent and is completely non-verbal. She does not ask for her needs and she cries when she is uncomfortable. However, she will sing songs. Even though she's nonverbal, she sings songs, and echolalia for TV advertisements, film songs, and rhymes is meaninglessly repeated all day over. Fourth case study is about a 35-year-old man post TBI who has severe cognitive impairment post TBI, which was 4 months prior. And he was a bank employee earlier and now is completely dependent on others for basic needs. So basically, the questions for each shall be: do we need to consider AAC right away, or should we wait and try other ways first? Or how do we exactly decide? Second question will be: what type of AAC should be considered? Then how do I exactly start? What will be my initial goals? And how will I know when to move on to the next step? What if it doesn't work out? And how long should I wait before moving on to another step or another strategy or another type of AAC? What if this does not show results? How do I decide on my prognosis? So, ma'am, over to you.
Okay. Hi, everyone. So basically, when we hear these four different cases and we think they're all different and their needs are different, their ages are different, their levels are different, and then we think, okay, we need to recommend different things for them. But the point is, when we speak, when we talk to each other, when we talk to any child, when we talk to an adult, we use the same language. So then why should their AAC language be different? So the point is that you expose them to the exact same AAC system. You give them the full system. So we say you give them a robust system. You give them a high-tech system. Expose them to the entire language. The difference will be your expectations from them, and the difference will be the goals you set for each person. So, for example, like I just want to, can I screen share?
Yes, ma'am, sure. Just a second. Yes, ma'am.
One second. All right. Okay, so this is an iPad, okay, system with an app. So like Avaz, there's Prolo Q. There are a lot of these communication apps, right? And the iPad, as you can see, is in this sturdy case. So it cannot, even if it's knocked over, it's not going to be broken. Nothing's going to happen. So the point is that I would recommend this, okay, for someone who did not have physical difficulty. So say for the 10-year-old who's on the spectrum, or for even the younger child, okay, I would recommend this, okay, so that they can use the touch screen and access it. I would definitely recommend it for the 35-year-old post a TPI. Now, the difference is what would be my goals, okay? For someone post a brain injury, okay, they could probably, go straight into the writing mode of the device, and you don't need to use pictures. So depending on their level, you can give them a full keyboard and they can type, and they can speak sentences, and they can communicate that way. For say someone, a 10-year-old who's on the spectrum, maybe you need to use pictures. Okay. For the even, I'm just going to pull that up. Sorry. The 3-year-old who has a global developmental delay. Okay. He could also use pictures. Maybe in his case, okay, the pictures need to be really much bigger. So you'd only maybe do 2 on a page, and then or maybe 1, and then slowly build it up, right? But for the child maybe who has multiple difficulties, okay, and access is a problem, maybe the touch screen is an issue and they can't use a touch screen, then I would always recommend that you link it to a switch, and I'll show you that too. Okay. Sorry. Sorry, give me 1 second. I lost it. There we go. Okay, so you link it to a switch, right, like this. And the switch basically links to your AAC system. It can link to your iPad, it can link to a system, and then it goes in a scanning mode. So it scans the series of pictures, or it scans 1 or 2 pictures, and the child presses the switch to select what they want. Okay, again, if the person has difficulties even activating a switch, you can use an eye gaze system. Okay, so that's the eye gaze part. So they look at that, and it picks up on the amount of time that they look at it. Again, it goes in a scanning system, and then it activates what they've looked at. Okay, so these are some options for people who have difficulties accessing the device. Okay, earlier on, okay, and again, if cost is a concern, you can use something, a lower tech system like this, like a GoTalk, okay, where the person can press down on it. And here you're limited by the number of words you can put in. So this is a 20 plus, you can have a 9 plus or a 4 plus, and there are 3 levels you can change. So basically, if you have 20 into 3 levels, you'll only have 60 pictures you can expose the child to. Okay, so these are some options. So if cost is an issue, okay, you can start with something lower tech. Okay, you can also start with just a picture book. Okay, just print out pictures, put it up in a picture book, and let the child pull it out to ask for what he wants. Okay, again, it can be only 1 or 2 pictures per page, but that's also an alternative system. If that's going okay, sometimes parents are skeptical. We don't want to like jump in and spend this kind of money if we don't know if it's going to work. So you can start with a picture book, then go on to an electronic system. Okay, but the point is, honestly, when you start the other way, when you start with the electronic system, you start seeing the results much faster, because a child gets a lot more motivated because they get that auditory feedback right away. They press it, they hear it, they get that feedback, and then they are more motivated to use it. So honestly, if you can convince people to go the higher way first, it makes a big difference. So that's one. The other thing is, where do you start? Okay, so where do you start with an AAC system is basically for someone who you say does not have communicative intent. So what do? You teach that communicative intent. You take something that they really like or want or ask for, and it can be something like even tickles, and you start pairing. I want tickle. You press tickle and then tickle the child. And you do that a couple of times so they get that link, right? Or it can even be throwing them in the air. It can be bouncing. It can be a body movement instead of something that they want to eat or drink or play with. Because sometimes kids may not really want to ask for any toy. It can be a hug, it can be a kiss, it can be a cuddle, it can be anything. But the point is you start by having the parent or the therapist model the way to do it for the child. So the first couple of sessions goes in just modeling. You're not trying to get the child to do anything. You're just trying to introduce that system into their life. So it's just modeling. The therapist models, the parent models at home, and you keep modeling, and that's how you kind of teach it to the child. Okay. Once they get that one step, then what? Okay. If they're asking for the thing they love, then what? Then you slowly start increasing that vocabulary the same way you do in any sort of therapy session. So you start getting them to ask for more things, call out family members, things like that. And then if they're at a one-word level, if they're at a not pointing, not doing anything, you start at a one-word level. If they are at that one-word level already, like you said in your one case where the child's already saying mama, papa, you start a little higher. You start with two-word phrases. So mama, bye. So you always start a level above the child or the individual, and you model it. And then that's how you keep progressing. Because as the person moves, you move higher. And that's how you progress, and that's how you do it. And and what if it doesn't work? Okay. The only way an AAC system is not going to work is if everybody is not on board with it. So if the therapist, if the family, if the environments the child is in, if they are all not on board with it, it will fail. If everybody is on board, there is no way it will fail. Because the child is communicating 100x more than they can just by crying or pointing or saying a few words. And that motivates anybody to want to do it further. So, but the thing is, the difference is that we have to set up the environment so that they can use their system. We have to make sure in social situations, in family gatherings, in school, we set it up so that the child can use the system. Basically, if we don't create enough opportunities, they're not going to be able to use it. And if it just sits in their bag or sits on their desk, they're going to lose the purpose of it. So it all comes down to the prognosis, all depends on us. The more we educate, the more we are educated ourselves, because this again isn't something that you get a huge course on when you study undergrad or masters. So it's something you kind of have to keep learning. And obviously, as technology keeps progressing, we have to keep up. And that's with any sort of technology we use. So similarly with AAC systems, you have to keep up with the technology. So the more you educate yourself, the more you can educate the family, and the more they can educate everyone in their environment so that the person can use it to the maximum potential.
Yes. Ma'am,
Right.
sorry for interrupting on this particular point. Can you just tell us a few points that we can use in our counseling for, parents? Because most of the parents are, most of the time they're not on board themselves with the idea of giving their child an AAC. So if you could just throw some light on that.
Sure. So, so basically it comes down to a lot of the times, and I get this a lot, where people are like, okay, how do we even broach this subject? How do we even tell the parent, how do we even show it? I say it, but then I demonstrate it. So I'll give you an example. So basically, I'll say, okay, AAC is great, all of that. And there's research that says it doesn't impede speech development. It actually makes it faster. because a lot of parents have this thing of my child's just going to point or press and they're not going to talk. And what's the motivation to talk? I mean, the motivation is to communicate. You have to first make them realize there's a difference between talking and communicating. There's no point a child just parroting what they hear because it's not what they really want to say. So the point is you want to get them to that point of understanding the difference between just talking and communication. That's one. The others, you can always show research, okay, it doesn't impede speech and all of that. But the best thing to do is to have a device with you and demonstrate it. So, and children pick up really quickly. So basically, even if, like, I'll give you an example. Like, I was in a session and I said, I have the device and I asked the child a question on the device, and I said, and I gave her an option of pressing yes or no. And her parent was like, well, she nods for yes and no. So I said, okay, great. Okay. But I went with it. And this kid in 1 second was like, yes, or whatever it was. And then the parent asked her the same question, okay, with no visual option. And the child ignored her. And she asked it again, and the child ignored her. And basically, she had to go up to 4 times until the child responded. So it's, it's when they see it, when it goes in so many ways, their response time also becomes so much faster. So nodding may not have been the fastest mode for her.
Right.
It's probably what she used because she had no other option. So when you can show that, I think it's easier for a parent to also kind of believe in it. And, definitely something like that.
Yes, definitely.
So,
That makes sense. Like actually showing them what it can give instead of, because
true.
people generally live in the notion of what they've heard from their environment and what they expect without knowing much about the device itself. Okay. And ma'am, one more
And
question.
the other thing with an AAC system, the other thing I wanted to point out also is that in a lot of cases, it's not permanent. Like especially in the case of, say, someone with a TBI. Okay, like we've worked with people with TBI with systems, and it gives them that place in the beginning when they are so frustrated and they have no way of getting their words out, and they're able to type it out or use pictures or whatever it is. But as the swelling, as the everything starts improving and speech starts coming back, in some cases, when it does come back, then you can fade out the AAC system.
Right.
So it's not like, it for every case, it has to be lifelong. But in a lot of cases, it is. And again, that's not to say that they won't get verbal speech too. And, the person decides what's easier for them at that point. They use what's easier. The point is that system should always be accessible so that if they find that easier, they have it to use.
Exactly. That makes sense. Okay. Ma'am, you partly answered what I was asking. And one more question I was actually thinking of is, so one of the case we mentioned, it's more of the cognitive issues. So what and how do we go about in such cases where the cognition is because AAC will require at least some basic cognition to do the pressing, to make choices and then answer you back. So how will we start off in such cases?
So for someone who has cognitive difficulties, globally delayed, all of that, okay, the child is still communicating in some way. Okay, so how do kids communicate? Either they vocalize, or they cry, or they point, or they pull the adult to what they want. So what you're doing is replacing all that with a picture. And that's where you're starting. And the point is that someone with cognitive difficulties, maybe you're not asking them to make a picture choice. You're modeling it, one picture, but you're getting a step above just crying.
Right.
So so again, they may cry for their water bottle that's in their mom's bag. Okay, now she knows that cry means he's thirsty. But you give the device, you press water, and then give the water. And you model it, or the mom models it, so the child starts getting, okay, this is water. And by doing this, I am getting it. So they may not be able to make choices, but at least they can make one request.
Yes, that Okay, understood. Yes, that's pretty clear. And that's how we will start, right? Like how we generally do in our CSLD cases. Like
Exactly.
start with something they like, and then we go on to the vocab in their general environment, common objects.
Exactly.
Yeah.
Exactly. Exactly. Start with highly motivating things.
Yes. Okay. Understood.
So basically, in conclusion, I would like to say is that the question that I again get a lot is, should we start AAC now or should we wait? And my point is, wait for what? Start it right away, because, you know, later maybe you don't need it, and that's okay. But at least start with more, give the child more to build on. It's basically like you're giving them everything. And then if it's not required, fade it out. And if it is required and it's helping the child, just continue with it. But there's no harm in giving. It's the same thing, right? You're talking to them right away from the beginning. You're not keeping quiet just because they are not speaking. So then why not give them a system? And then if not needed, fade it out. So yeah, that's
Thank
what
you
I'd like
so
to say.
Thank you so much, ma'am. It was pretty clear, and like it was definitely helpful for like junior clinicians like us. Like we are always confused, and you clear a lot of doubts about it. And definitely, it needs like, although we are not very experienced with it, but we need to start, and it really can make a difference in a lesser time than what we are keeping on trying. That someone who is completely nonverbal, we waste a lot of time actually. So like starting right away is something, a key point that all of us need to remember. Thank you so much, ma'am. Arusha, you would like to conclude?
Most welcome.
So overall it was a very comprehensive answer. Like even the main point, like that what I took away was the patient could have any different kind of, the presentations, clinical presentations, but my goal has to be clear that I have to expose him to the language he would anyway get, and he would anyway, if
Yeah.
he's a child or an adult, like no, whoever it is. And it's almost the same, it's just instead of words I'm using an AAC. So that's something even I wanted to be clear in my head, because I am always confused when I am in a class. I'm lost. I honestly don't know where to start. So at least I think I have a start point now, and then I think it's more like the therapy that we take, and so I can build up on that. So that
Right.
completely
Right.
makes sense to me.
Okay. Thank
So
you so
yeah.
much, ma'am.
Thank you so much,
Most
ma'am.
welcome. Most welcome. Bye.